so don't stop at that. Okay, now we are going to the receptors. So all what happens with the help of drugs, with the help of acetylcholine, the effects they refer to receptors and their localization, their effects which they provoke. So that's why you have to study and you have to learn where are the M-choline receptors located and what do they do in our body. So let's see. Firstly, localization. Non-striated muscles. They are smooth muscles, yes? In the smooth muscles of GIT, the respiratory tract, the uterus, the iris sphincter muscle, we have the effects of constriction if we stimulate M-choline receptors. Remember, yes, that all this refers to stimulation of choline receptors. Надо здесь написать stimulation. I will write that stimulation of these receptors, of M receptors. So if we stimulate the choline receptors, we have this effects of constriction of all these parts. In the heart, what happens? If you stimulate the M-choline receptor in the heart, you have the negative inotropic effect. What is it? This is the reduction of the contraction in the myocardium. So reduction of the contraction of the myocardium. Okay. Next, in our glands, salivary glands, sweat glands, lacrimal glands, if we stimulate M-choline receptors, we have increase of secretion of these glands. Of course, the glands of GIT, the glands of respiratory tract, they also have the same effect. They also will increase the secretion if we stimulate them. Not only the muscles, yes, not only the smooth muscles, but the glands in those organs, they also can be stimulated by M-choline receptors. Okay, what is next? Talking about the stomach, as I already mentioned that the increase of the glands will be observed, and that's why we have that increase of pepsinogen and HCl secretion also will be higher. And also what we have here, the presynaptic membrane. This is a little bit special because here we discuss the organs, and this is the cellular level, on the cellular level. If we stimulate the presynaptic membrane, it will give the negative feedback and decrease the acetylcholine release. So this is the effect which you also should remember. So we have already discussed that there are several subtypes of choline receptors. These, located in the presynaptic membrane, are usually M2 receptors. And the rest, and also including M2 receptors, they are postsynaptic. So these are presynaptic, these are postsynaptic. And in postsynaptic receptors, you have M1, M2, M3, M4, and M5 choline receptors. So the acetylcholine, which affects the M1 choline receptors, activates the CNS and activates the ganglions. When acetylcholine binds to M2 choline receptors, it causes the heart depression. We already discussed that, reduction of the contraction of myocardium, yes? When acetylcholine stimulates M3 choline receptors, we have the contraction of the non-striated muscles and glands. The smooth muscles contract and the glands start secreting more. When acetylcholine stimulates the M4 choline receptors, we observe the effects in heart, CNS, and lung vessels, and M5 are located in CNS, salivary glands, and iris. Of course, guys, please don't think that only M5 here and only M2 here. No, not only. These are like the examples. these are only the examples. It doesn't mean that you cannot find the M1 receptors in the smooth muscles. No, it doesn't mean that. They can be located also there. Okay, the different type of cholinereceptors is N-cholinereceptors. N-cholinereceptors, they are called N because they are nicotine-sensitive cholinereceptors. Так, надо перенести вот это сюда. Вы тут не видите, да, ничего? Sorry, maybe you didn't see that. Nicotine-sensitive cholinereceptors. Where are they located? They are located in the CNS and responsible for the activation of CNS, in the carotid bulb that also activates and brings some reflex. For example, it can stimulate the breath or it can stimulate the heartbeat. So this is a powerful, how to say it, like reflex zone, powerful reflex zone in our body. So if we stimulate something there, we have many reflex response. Then also we have sympathetic ganglions, which include N-cholinereceptors, and well, here this gives us the blood vessel constriction, but this is again only the one example. Not only blood vessels, but also the heart work and also the GIT work can be affected, and many other things. Medulla of adrenal glands. By affecting on that, we have adrenaline increase of secretion to the blood. And in these parasympathetic glands, sorry, S is missing here, parasympathetic ganglions, we have the stimulation of GIT, the contraction of bronchus, the contraction of smooth muscles, and the stimulation of different glands secretion. So all this refers to N-cholinereceptors, guys. So you can see that actually some effects are the same when we stimulate M-cholinereceptors directly in the organs and when we stimulate N-cholinereceptors in the ganglions. Because why? Because all these organs are innervated by the same nerves, but here it is indirect action, and in case of M-cholinereceptors, this is more direct action. Well, the main effects observed during stimulation of the parasympathetic nerves are here. So we have already discussed them, that in myocardium it will be decrease of heart force, in enteroventricular node it will be bradycardia, yes, less contractions in a minute. In smooth muscles, non-straight muscles, we have the increase of contraction, relaxing of the sphincters. By the way, yes, pay attention that the smooth muscles will contract, but sphincters will not. Well, in the glands, we have stimulating of secretion, and in blood vessels, we have vasorelaxation. Well, what is the interesting thing about the M-cholinereceptors of the eye? We have a big therapeutic effect using the M-cholinergic drugs for the eye. Okay, let's see firstly what do we have here. In the normal pupil, we have the musculus sphincter pupilla and musculus dilatator pupilla. So they are relaxed and they have like no effect on the pupil, and it stays normal. So you can see this picture. In case of M-cholinergic effect, what happens? This muscle, the inner muscle, yes, musculus dilatator. Sorry, the inner muscle sphincter. The inner muscle sphincter will be stimulated by M-cholinomimetics. Don't be confused. If the sphincter is located in GIT, it will be relaxed, but the sphincter in the eye will be stimulated. Sphincter of the eye. Okay, So it will be stimulated, and you see what happens with the pupil. It becomes small, it becomes smaller. So this way we have meiosis. Also, what happens? The stimulation of M. cholinereceptors in the eye decreases the intraocular pressure, which is very good in case of glaucoma. What happens actually with that glaucoma? Here in this angle we have a chamber from which the fluid should outflow from the eye, and if the this corner is blocked, then a lot of fluid accumulates in the eye and makes a big pressure. If we have the M-cholinomimetic effect, it stimulates the muscles which help to open this I forgot the word. I just used it 1 minute ago and now I forgot it. Well, this space will be free, and a lot of outflow of the fluid can happen. So that's how we reduce the amount of intraocular fluid, and we reduce the pressure which it makes on the eye. So this is very good and useful in glaucoma. What else in the eye we have? We have this spasm of accommodation. Why? Because we have the ciliary muscles which control our crystalline lens. They control this lens, and they how round is it, and how how it makes the light break inside. So in case of normal crystalline lens, we have the lens in the shape of oval, and in case of this we can see far away or like in the middle. But in accommodation spasm, what happens? The lens becomes more round, and the person can see closer, and he cannot see further. So person can start thinking, oh my god, I'm losing my eyesight. But no, maybe this is just the spasm of accommodation which happens because of the muscles. Here the ciliary muscle will be contracted, and that's why this lens changes the form. Okay, what can we do? We can do the opposite process here. If we stimulate the muscles, then it makes the accommodation spasm. But also we can not stimulate, we can block the M. cholinereceptors of the ciliary muscle here. And if we block, everything comes to the normal. If you block this, here the muscle becomes relaxed, and the lens becomes again oval, and the patient again can see far away, far away. And now let's look at the classification and try to remember some drug names. Well, I will not read them. I think that if you want, you can stop the video here and make a screenshot or write it down to your notebook. So here are the classification, and we have some drugs which are M and N cholinomimetics. That means they stimulate both M and N cholinereceptors. Also, we have anticholinesterase drugs. What are they? They block cholinesterase. You remember what is it? The vase with the flowers, yes? The enzyme which breaks down the acetylcholine. If you block this enzyme, nobody will break down the acetylcholine, and acetylcholine will accumulate and affect more. As we remember, acetylcholine can affect M. cholinereceptors and N. cholinereceptors also. That's why acetylcholinesterase blockers, they indirectly activate all the types of these receptors. Okay. Also, we have M. cholinomimetics. They are drugs which only stimulate M-cholinergic, and we have stimulants for N-cholinergic receptors. You see the difference. Так, ага. So here we have the group of blockers. The M-cholinergic blockers, atropine-like drugs, they block only M-cholinergic receptors, and N-cholinergic blockers, they block N-cholinergic receptors. So here you can see a little bit different again. Sorry for Russian, ganglion blocking drugs. Yes, here, ganglion. So which work only in ganglions, and here 6.2 they work in muscles, skeletal muscles, of course, because we have N-cholinergic receptors only in skeletal muscles. Okay, so here a little bit chemical structure to understand how the M-cholinergic blockers work. M-cholinergic blockers are esters of organic base and aromatic acid which eliminate the effects of the parasympathetic part of the autonomic nervous system. Why? Why this is they are the esters? Because the acetylcholine is also an ester. Acetylcholine has this group COO, and the blocker should also have this group COO, and here it is. If the structure would be different, they would not bind to the M-cholinergic receptors. What we can see here is that the drug atropine has not only ester group, but also this group, which is the same to acetylcholine. So again, this drug is quite powerful. It has the structure very similar to acetylcholine. That's why our body thinks that the receptor should bind with him, with atropine, and it has quite pronounced effect. Yes, already we have seen that. So atropine-like agents, they block M-cholinergic receptors of the effector organs, and by that prevent interaction with the receptors of the neurotransmitter acetylcholine. So you see, if M-cholinergic blocker is here, acetylcholine cannot bind here, and that reduces the effects of parasympathetic nervous irritation. What can be the effects? Firstly, it will be the suppression of secretorial activity of the glands. Secondly, reduction of the tone and contractile activity of smooth muscles. So here you can see, before M-cholinergic blockers, if the muscles are contracted and a lot of mucus is here, after the M-cholinergic blockers, the muscles go relaxed and the mucus goes like drier, because less mucus will be secreted from the glands. And this helps, for example, in case of bronchoconstriction and bronchial asthma. Also, what happens with the heart, this is the increase in heart rate, because we remember, yes, that M-cholinergic blockers, M-cholinergic mimetics, they stimulate M-cholinergic receptors, which decrease the work of heart. And if you block them, work of heart will increase, logically, yes? So, next. M-cholinergic blockers effects also can be the reducing of the smooth muscles of the eye. We talked about the glaucoma, yes, that it would be helpful to contract the muscles in glaucoma to reduce the intraocular pressure. And if you have M-cholinergic blockers, it will be opposite. It will be pupil dilation, because they relax, yes, the relaxed muscle, and the pupil will be dilated. So we will have mydriasis. Also, the intraocular pressure will be increased. That is worse in case of glaucoma. This is very dangerous. So we shouldn't use M-cholinergic blockers in glaucoma. You see that? Yes. So it is contraindicated. Also, we have paralysis of accommodation. Paralysis of accommodation, what I told you that about in spasm of accommodation, we can use M-cholinergic blockers to make the paralysis. If the spasm of accommodation, then your patient can see only in front of him, but not far away. But if you have paralysis of accommodation, this is opposite. You can see far away, but you cannot see what is close to you. Okay, this is paralysis of accommodation. And here we can show it here that, yes, M-cholinergic blocker gives you this effect, the dilation of the pupil. What is here? Here we discussed about the increase of intraocular pressure. If here, this is the eye, the front of the eye, this is the back of the eye, and the Schlemm's channel, почему канал, не знаю, channel, it's the channel, of course, is the place where the fluid should outflow from here. Yes, this is the zinc zonule and the crystalline lens. So what happens? The fluid should outflow here. You can see, yes, in the Schlemm's channel, this blue arrow shows us the movement of the fluid, of the intraocular fluid. Okay, but when the muscles are contracted, when they are relaxed, they like block this way to the Schlemm's channel, and you see the fluid cannot outflow from here, and we have a lot of fluid accumulated here inside this chamber, ocular anterior chamber, which makes a lot of intraocular pressure. The pressure becomes high. Now let's go to the paralysis of accommodation, how it happens. Here we have this zinc zonule, which is controlled by ciliary muscle and which controls the lens. I already told you the lens should be oval to make the normal accommodation. So when it is normal, it breaks the light here directly in the back of the eye, and you can see normally. But what happens if the muscles are contracted? What happens? You see, yes, that form of the lens becomes different, and now you can see only the subjects which are far away from you. Now, M-cholinergic blockers are classified not only on which receptors they affect, they also are classified on the localization of action. They have central and peripheral action, both actions, yes, only peripheral and only central. So because of this different effect, they are used, of course, in different diseases, affecting on CNS only, affecting on organs only, peripheral, and affecting everywhere. Well, about the atropine itself, this is the drug which we get from the plant belladonna or henbane, and these alkaloids like atropine and scopolamine and platyphyllene are found from these beautiful plants. These drugs are very toxic because they have these alkaloids, and they can affect in all our organs and systems. So you should be aware of these drugs. Well, atropine is currently obtained synthetically, chemically. So now we don't have to use the plants to get some atropine. The name Atropa belladonna is paradoxal because the term atropos means 3 fates leading to an inglorious end of life, and belladonna means a charming woman. So this term is due to the fact that the extract from this plant, belladonna, buried by the beauties of the Venetian court of the eyes, gave them a glow, expanded the pupils. So what did they do? They took the plant, made an extract, and put it in the eye, like the eye drops. Of course, the pupil became wider, and they had such a glow in the eyes. Well, it was maybe beautiful, but it was very, very dangerous. So this is the games of atropine. The structure of atropine, you have already seen that, yes? So this first chemical constitution is the tropine alcohol with the tropic acid. Again, alcohol with acid gives us the ester. So these two parts gives us different effects. Again, sorry for this Russian, I don't know why. Well, tropine alcohol gives you the exciting of CNS. I will write it here. CNS exciting. CNS exciting. The tropic acid gives you the local anesthetic effect. Local anesthesia. And M-choline blocking effect can be observed only in case of combination. You see, this is between. So M-choline blocking, no, M-blocking, let it be M-block. M-blocking activity is observed only in case of using them both together. So the atropine, if it will be broken down into two separate parts, the alcohol itself and the tropic acid itself, it will give you only one effect, the CNS exciting or local anesthesia. But only together they can give M-choline blocking effect. Well, I hope this is understandable, that blocking can be observed only when the whole molecule is used. Okay. Atropine-containing drugs, they are atropine sulfate, extract of belladonna, tincture of belladonna, and also hyoscyamus oleum. Oil, I mean oil. So these drugs are rarely used now. Well, talking about this atropine again, the toxicity, the effects, the therapeutic effects and toxicity, they depend on dose. How much atropine do you use? So if we have the dose of 0.5 milligrams only, we have like slightly effecting on dry skin, slight dry mouth, and reduced heart rate. And by increasing the dose, we have more and more effects on other organs, not only the skin, yes, and mouth, but other organs. And in fact, when you overdose 20 times, yes, you see, 20 times, we have already quite serious complications like delirium, coma, hallucinations, and so on. So you should be very careful with atropine and overdosing it. Scopolamine. Scopolamine is the drug, atropine-like alkaloid. This is also an ester, but the alcohol is scopian, and again tropic acid, and it inhibits the central nervous system, unlike the atropine. You see, unlike atropine, it inhibits the central nervous system, causes sedative and mild hypnotic effects. So opposite effect from atropine. The use of scopolamine can cause amnesia, loss of memory, and administered in sea and air sickness as a sedative and for the treatment of Parkinsonism. So in this case, the rest effects will be the same, but only CNS effects will differ from atropine. The indications of these drugs. For example, they can be used in spasm of smooth muscles, different, intestine, bile, urinary tract, and so on. Also for bronchial asthma, I already told you that we can dilate the bronchi by using of these drugs. The gastric and duodenal ulcer. Why? Because they reduce the secretion of the glands, and if we have less HCl, so we have less irritation of the mucosa. In anesthetic practice or pre-medication, why? Because it stops again, yes, stops the effects of different glands, of GIT, and so on. So in our surgery, it is useful. For the study of the fundus. I don't actually, yes, this is for the eye. If you want to see what's going on in the backside of your eyeball. Okay, and in case of poisoning with M-cholinomimetics and anticholine esterase agents, of course, they are opposite to M-cholinomimetics. So if you overdose with M-cholinomimetics, you should block logically because it gives opposite effect. And in vestibular disorders that we just discussed, scopolamine can be administered for the seasickness if you have that